I'm Sarhanis. I'm a consultant gynecologist at the Clementine Churchill Hospital. My main interest is cervical smears, colposcopy, complex gynecological procedures, cancer, and keyhole operations, including hysterectomy. So, what I'm going to be sort of discussing with you today is something very close to my heart, and also something that we face every day. And I'm going to go straight to the point, because we'll go straight to case study number 1. Now you will notice that this case has got real dates. That's because it's a real case. And also you can see that it's something that is still ongoing. And it just happens that this is one of the cases that was referred to me at the Clementine Churchill Hospital. 60-year-old lady goes to her GP with vague abdominal pain, describing morbid discomfort about 6 weeks. So, I mean, this is simply me copying the GP letter here. Suprapubic pain aggravated by movement, relieved by drinking loads of fluids, no weight loss, good appetite, urine dipstick positive nitrites, leukocytes. On examination, pain on palpation, suprapubic tenderness. Patient requested a gynae referral. She was seen by a trainee in the practice at the time. The case was discussed with a senior partner. They said it was probably UTI, prescribed some trimethoprim, and arranged a scan in the community. So, just to carry on a bit, I'm going to do this a bit back to front, so I'll give you some clues here, then I'll do the presentation, and the rest of it I'll go around and discuss it with you, because I really need your feedback. The ultrasound report that it was asked for, the clinical history was lower abdominal pain. Now the report, as I read it in the GP letter, the liver, gallbladder, bile ducts, pancreas, spleen, aorta, and kidneys are unremarkable. There's a simple cyst in the liver, blah, blah. Common simple hepatic cyst, no significant abnormalities. Now, for the ones of you who are very keen on these things, you will have noticed that the clinical request is about the lower abdominal pain, and there's hardly anything about lower abdominal organs. But that is the scan report. Patient returns to GP surgery a couple of weeks later, continues to complain of lower abdominal discomfort, seen by another senior GP, who examines and identifies a large smooth mass arising from the pelvis, urgent referral to the Clementine Churchill Hospital. As I said, this is something that I took from the GP referral letter. So it's happening today. Clearly, 60-year-old pelvic mass, I'm sure all of us are thinking about ovarian cancer. And I will be very, very pleased if at the end of this presentation you say to me, you know what, I learned nothing. That'd be very good, because it means you are at the forefront of where you should be, and that's exactly where we would like you to be. But if I manage to add something to your knowledge, that'd be great. Just to remind ourselves, ovarian cancer is still the leading cause of death from gynecological cancers in the UK, and its incidence is rising. It's the 5th most common cancer in women, and has a lifetime risk of about 2% in England and Wales. Some figures here, which shows you that there's not much difference whether you live in England, Scotland, or Wales. The incidence is similar, but the numbers we're talking about, I think that's the main thing here. The numbers are in the thousands. So in excess of 6,500 women will develop ovarian cancer every year. Unfortunately, a lot of them will die of it, and that hasn't changed. So, why am I talking about the USA? Because a lot of the new guidance that I'm going to refer to is because of studies that were done in the USA. Again, in the USA, the ovarian cancer is the leading cause of gynecological malignancies. Again, it's the 5th commonest cause. They had about 22,000 new cases with 14,000 deaths in 2010. Less than 40% of women are cured, and 70% of patients present with advanced disease. This is the same demographics that you can see in the UK. Now, I'm in charge of the gynae cancer services at Northwick Park and Central Middlesex, so this is a bit of an old slide, but nothing much has changed. And we're very grateful because the 2-week referrals are, very healthy. The numbers, very, very healthy. Actually, I can tell you, because I'm part of the London Cancer Alliance, that in Brendan Harrow, we are the second largest referrer numbers than any other place in London. So lots and lots of people are referred. You guys are very, very acute in thinking about cancer. The number of cancers hasn't really changed for the last 10, 15 years that I've been there. The magic number in Brendan Harrow is just in excess of 100, and the number of ovarian cancers that we pick up is about 36. Now, you may say small numbers, it doesn't really matter. The service we're running, both at Northwick Park and the Clementine, is to make sure that we identify who is malignant and who is benign, and that's absolutely fine. So you would expect that out of 1,500 referrals, it would be easy to pick up the 36 ovarian cancers, whether it's NHS or private. Let's go a bit on the basics, because sometimes taking a history is a good idea to remember some of the risk factors. Nulliparity, early menarche, and late menopause. Again, I apologize for you that you know these things already. Prolonged ovulation induction, the role of BRCA1, HRT, controversial, I'm not going to go into that. The bottom line here is women who ovulate more are more at risk of developing ovarian cancer. So the common denominator in all of this is the number of ovulations. And what I usually say, if you go back a couple of, maybe 3 or 4 generations, you may find that women in their 30s, they didn't perhaps have a career as they do nowadays. They tend to get married rather young, have a lot of children. When you're pregnant, you don't ovulate. Therefore, after that, you breastfeed. Therefore, you don't ovulate. So women between the age of 18 and 30 may have had no more than 20 ovulations, and maybe half of them resulted in a pregnancy. Whereas nowadays, between the age of 18 and 30, unless someone is on the pill, they're going to have hundreds of ovulations. And this is why we're looking at an increase in the incidence of ovarian cancer. Again, protective factors, early parity breastfeeding, not so many ovulations, hysterectomy. It's interesting, and we'll come back to that in a minute. Tubal ligation is something that we now know is protecting against ovarian cancer. You may say, well, how does this make sense? Well, a third of so-called ovarian cancers we now know come with the fallopian tubes. So I'm saying to all of my colleagues who do benign gynecology, if you're going to do a hysterectomy, take the tubes out. You may just save this woman's life. It makes no difference to her. Do not leave them behind. The combined oral contraceptive is obviously a protective factor, and we now know that these factors can reduce the incidence of between 30 and 60%. Now, of course, you're not going to tell your patients, go have a hysterectomy or go have your tubes ligated, but the message that the combined oral contraceptive does protect against ovarian cancer is something that we need to get across. And I think that's a very, very good message. Does race or social group influence risk? There's no studies in the UK, but in the USA, white women, by and large, are the ones who are the highest risk of ovarian cancer. This may be a link to number of pregnancies and breastfeeding, because, as we know, both protect against ovarian cancer. By and large, in this part of the world, ovarian cancer is a white woman's disease, and that's something also to remember when we're thinking about risks. Now, there's a problem, and the problem is that when we compared England, and this is a brand new study, it's been published in the National Cancer Intelligence Network. If anybody wants, there is a leaflet that I've given, and you're welcome to have a copy of. They compared the 1-year survival between various countries in the Western world. Unfortunately, England and other UK countries did not fare very well. So, in England, the 5-year survival is as good or as bad as any other country. The 1-year survival is worse. So how can this be? Well, they looked into that. They looked at almost 17,000 women with ovarian cancer diagnosed between 2006 and 2008. And a third of them were diagnosed in the first year, and they died in the first year. Sorry, a third of them died in the first year. And half of them actually died in the first 2 months. And women who are over the age of 70, and particularly over the age of 80, have much higher mortality. So clearly, advanced age is a risk factor for someone not to survive the first year. There's not a lot anyone can do about that. But this is really the important message, that patients who were diagnosed by emergency presentation have a much worse mortality. Out of all the women, the 17,000 that we talked about, 5,000 came via A&E, and 56% died in the first year. And this doesn't look very good at all, because this is not the case in other countries. So what's happening? How can we perhaps be able to identify these women who may have ovarian cancer in primary care and not ending up in A&E? Because we know that once they are in A&E, the figures are not very good at all. There's a lot of work going on about that, and I don't pretend to have the answer, because at the moment the National Cancer Intelligence Network is working on it, and I'm part of the study. But the key messages from there is, for women with ovarian cancer, mortality is high in the first 2 months after diagnosis. The mortality is particularly high amongst elderly patients and those diagnosed by an emergency presentation route, i.e. A&E. And unfortunately, women with combination of advanced age and emergency presentation have even a higher mortality. Right, so there is a complete change in the approach for ovarian cancer nowadays. Just to remind you about the first case that we just started presenting, nobody did a CA125 test. But that's the guidance. It's been in place for 2 years. Now, this is where the problem starts. What are the suggestive symptoms? Unfortunately, they are not specific, and we know that. Persistent abdominal distension, women describe it as bloating. Loss of appetite, feeling full, pelvic or abdominal pain, increased urinary urgency or frequency. We heard Mr. Lucas say that the pelvic mass sitting on the bladder will give you the symptoms. We need to think about these things. Unexplained weight loss goes without saying, or fatigue. One of the key points that I learned even very recently is the unexplained changes in bowel habit or symptoms that suggest irritable bowel syndrome in women over 50. Apparently, I'm told reliably by my gastroenterology colleagues that it's very unusual for IBS to start at 50 and over. So if somebody comes and says, I've got symptoms of IBS, there's something new and something is happening, it may be worthwhile thinking laterally. You may save somebody's life. So the key priorities is to carry appropriate assessment, and I'm simply copying this from the NICE guidance for ovarian cancer in any woman over 50 who has symptoms that suggest IBS, because it rarely presents for the first time in women of this age group. So the key age is 50, the key test is CA125, the key symptoms are usually gastrointestinal. Now, what is persistent? For at least 1 month. What is frequent? The magic number 12 came out of the American studies. They identified that people who persistently come to you and you say, I've seen this woman 12 times. Or this woman tells me she had the symptoms last month for 12 times. Think ovarian cancer. And that's all come out of research. So women with raised CA125 have an ultrasound of their abdomen and pelvis within 2 weeks of receiving the CA125 test results. So they recommend they do the CA125 test and the ultrasound afterwards. Now, if you do it the other way around, it really doesn't matter too much as long as it's done. Now, my clinics are full of women on the NHS with normal CA125 or raised CA125 but normal ultrasound, and not confirmed diagnosis, but continue to have symptoms. This is very woolly from NICE. It says reassessed by the GP within 1 month. What they mean by here is, look, it probably isn't ovarian cancer, there's something else wrong with this woman, start thinking about other things now, not ovarian cancer. And this is where things get slightly more complicated for you and for us. Because CA125, we all know it as a cancer test. As a matter of fact, I get a fair amount of referrals say, oh, I just did a CA125 on this woman, and it's high, what do I do next? My answer is, I don't know, why did you do it? Because there's so many conditions that will raise CA125. So doing CA125 levels in a young woman who ovulates or maybe pregnant or menstruates, there's little point. Because these are just physiological conditions that will raise CA125. But there are also benign gynecological conditions. Endometriosis, no doubt Mr. Disso talked to you about this. Sorry, I wasn't here at the time. Endometriosis, benign ovarian cyst, fibroids. All of this raise CA125. So if you've got somebody who said, I've got fibroids, I might as well do a CA125. Maybe ask why. Why am I doing it? Maybe there's symptoms, and I appreciate that, but just routinely doing it doesn't help anyone. Other non-malignant causes, autoimmune disease, very, very common, sarcoidosis, GI conditions, colitis, diverticulitis, hepatic lesions. I get a lot of referrals. This lady is known to have cirrhosis, got high CA125. Yes, I know. That's because she's got cirrhosis. She really doesn't need to be in a gynae clinic. Pericarditis, pancreatitis, basically any kind of inflammation will raise CA125 levels as well as renal disease. So CA125 is a good test, but on its own it means very little. And we have to think very carefully about doing this in women who are relatively young. So there are malignant cases. Other cancers will raise CA125. This is nothing to do necessarily with primary care. I get a fair amount of referrals from the GI cancer team saying this woman has got disseminated malignancy and CA125 is high. I know any malignancy will raise it, and nothing we can do about that. Now, your patients already know these things because a charity that I work very closely with, and I took the liberty of simply copying a leaflet that a lot of ladies already have, know that if they have these symptoms, they should see the GP. And I'm quite interested to see, number 3, if you think you need an appointment, be assertive and don't put it off. Now, that's what women say. That's what women are advised to say, and they are right. And this is not something that we have written. As you can see, this set of top tips was developed by a workshop group comprising people affected by ovarian cancer and GPs. And sometimes we get frustrated and say, but why? Why do they leave it so late? And I think the answer is because it's difficult. And what we're trying to do today is perhaps alert you to the fact that this is happening. It's happening today. The case I gave you is of March. The guidance is out for 2 years. People know about it. Patients know about it. And it's difficult. I also know from the same charity that nowadays people have a lot of high expectations. They want us to identify everything 100%. They don't want anything to be missed. And apparently not identifying an ovarian cancer early enough is a serious source of litigation against GPs, so I'm told. So this is something that perhaps we can help you with. So the learning points from today is ovarian masses in postmenopausal women, think cancer. Ovarian cancer is still one of the most common and lethal cancers. Mortality in the first year is too high in the UK. 5-year survival is similar to other countries. Up to a third of ovarian cancers present to A&E. I gave you some figures of the thousands of women that we see every week in the 2-week wait clinic at Northwick Park and Central Middlesex. And I told you we've got about 36 cancers. The reality is only a third of them have come through the 2-week wait. Why is that? The main message to take out today is that there's a resource shift towards early identification. It makes absolute sense that if we identify a cancer early, the survival will be much better. And also, the book says it's a silent cancer. It's not. It can present with non-specific but well-documented symptoms, And I do believe that the most important people in the early identification is you and not us. IBS rarely appears for the first time over the age of 50. Other persisting non-specific symptoms, usually of GI origin, may indicate ovarian cancer. CA125 is a must, is a useful test, but unfortunately is not specific. Has limited value in younger women. Many physiological and benign conditions will raise it. Imaging is important, but it's got to be done by the right people at the right place. Of course, one will refer to specialists, that's always the case. I'm not going to talk to you about risk of malignancy index, something we work on. We've got new ones. We have a fully functioning multidisciplinary team that works across Northwick Park and Clementine Churchill, and we manage all suspicious cancer cases, whether they're NHS or private, according to our network, Cancer Network guidelines. Thank you.